speakers is Dr. Arlene Sy-Reodica. Sorry if I pronounce your names wrong. Sorry. And so she is a critical educations and applications manager, life care solutions of ASEAN, and she's managers of GE Healthcare. And so she got her doctorate in medicine from University of Santo Tomas in Philippines, and also she got the she's from in medicines and surgeries, and so her master's is also from design in clinical trials at Universities of Edinburgh in UK, and she will give us in the topics of the use of early warning score for COVID-19 patients. Is very interesting, very interesting topics at this time, right? For so important for these situations. Please give a big hand for her. And okay, welcome. Hi, so you can start right now.
Thank you very much. So it's an honor and privilege to be invited in this RSU Conference of Science and Technology. Let me just...
It is our honor as well.
Okay. So let me just put my slides on.
Yeah, it is on the screen.
Okay. Hold on. Okay, it's not going on slideshow. Sorry, let me just... Okay, so my topic for this afternoon is the use of early warning score for COVID-19 patients. So my name is Dr. Arlene Sy-Reodica. So I am an anesthesiologist and intensive care specialist. So I also have a master's degree in clinical trials. And currently, I am the clinical education and applications manager for GE Healthcare in ASEAN. So my disclosure is I am employed by GE Healthcare, but I do not have any stock ownership or royalties from any publicly traded company. I do not hold any intellectual property rights or royalties to any technology. So what is early warning score? So early warning score is used in the hospital to identify patients at risk for deterioration. So before a patient goes into cardiac arrest or before a patient dies, usually the hours preceding the cardiac arrest or the hours preceding the death of the patient are actually coupled with deranged physiology. So meaning if you are monitoring the vital signs of your patients, the hours leading to the death of your patient will actually show you that the vital signs are no longer normal. Okay, so we use the parameters from early warning score to identify and respond to previously unrecognized deterioration in these patients. Because if you will just take, let's say, one parameter, you may not be able to see that the patient is actually deteriorating. So early warning score is actually a combination of multiple parameters to tell you that, hey, you should watch your patient more carefully because your patient is deteriorating already. So it's an international risk stratification system, which is developed to facilitate early detection of deterioration in hospitals. So basically, what we want to happen is we want to decrease the mortality rate of patients in the hospital by early detection. It also helps to increase the chances of improving the patient's outcome if we manage them early or if we do timely management of these patients. And these real-time scores that we are getting, so the real-time score for early warning score is actually able to assist the clinicians also when they make their decisions for the patient. So how should I manage my patient based on the scoring system? So actually, early warning score started in 1997 in the UK. So the very first early warning score was written by Morgan et al. And then they published it in the Intensive Care Society in the UK. So this was the very first early warning scoring system um, that was known to the clinicians. So in 2003, they decided to revise it or to modify it. So the early warning score of 1997 became called the Modified Early Warning Score, again in the UK. And Scotland created their own early warning score, which they called SEWS, or Scotland Early Warning Score. By 2007, the National Institute for Health and Clinical Excellence, actually, they are proponents also of early warning score. So in 2007, they published an article saying that they are recommending the use of these multiple parameters as aggregates for use in acute hospital settings. By 2012, the UK actually created another early warning scoring system, which they called the National Early Warning Score. And then in 2017, they revised it, so they called it the National Early Warning Score 2. So this was mostly started in the UK. So why is it important? What is early warning score? So the Royal College of Physicians actually said that if you do early detection of your patient, if you do timely management of your patient, and if the clinicians are competent, so the clinical response to the patient's deterioration. So if you have all three, then it will help to improve the clinical outcome in patients with acute illness. If you will look at the different hospitals across the globe, some hospitals will have their own early warning scoring system. So this is a track and trigger system that different hospitals will use. And then because of the scoring, they will identify and respond to patients who present or who will develop acute illness. So this led to the creation of the National Early Warning Score, or NEWS as we call it. So what is NEWS? So as I mentioned earlier, NEWS was created in 2012. So why did the NHS group in the UK create the National Early Warning Score? Because they noticed that different hospitals have their own scoring system. So if you are using different scoring systems, this hospital may label this patient as being acutely ill or deteriorating already. But once the patient is transferred to a different hospital, then if they have a different scoring system, patient may not be deteriorating in their scoring system. So that's why the NHS group felt that there is a need for standardization. So if you will look at the UK now, in this present setting, this one is actually widely used in the entire country. So again, National Early Warning Score was created in 2012, and then it was modified in 2017. So what was the goal of the National Early Warning Score? Of course, the first goal is to improve the assessment of acute illness of the patient. So again, we want to make sure that we detect this early so that we can do timely management. So number two, we want to make sure that clinical deterioration is detected. Number three, we want timely and competent clinical response to the deterioration that we are seeing, if ever. And then another aspect of the National Early Warning Score is the frequency of monitoring. Because normally, if a patient is transferred, let's say, to the general ward, patients are not monitored as frequently as when they are in ICU. That's why early warning score also aids the clinicians or even the nurses to say that, okay, I need to monitor my patients more often because so yet setting for the treatment of your patient. So meaning, which care area should my patient go to? Will my patients be okay in the general ward, or should I escalate my patient and bring my patient to high dependency unit or the ICU? Okay, so what are the parameters that are being monitored for the National Early Warning Score? So whether it's National Early Warning Score or the National Early Warning Score 2, these 6 parameters are what you will see. So they take into account the respiratory rate of the patient, the pulse rate of the patient, the level of consciousness of the patient, or if there is a new onset of confusion in your patients. We also assess the oxygen saturation and the systolic blood pressure, plus, of course, the temperature of your patient. So you will see on the diagram here, so there's a chart, the score is between 0 to 3. So each parameter will have its own scoring system between 0 to 3. So what is the difference between news and news 2 scoring? So if you will look at this slide, so the picture on the left is news 2 scoring. So on the left is news 2 scoring with the same parameters. However, there are two difference. Number one is the delirium in the patient. And then the second difference is the news 2 scoring takes into account the SpO2 scale 2. So they consider patients who are going into hypercapnic respiratory failure. So example will be patients, COPD patients. So that is included in news 2, which was not present in the original news of 2012. So how do we do this? What is the clinical response to news? So again, based on the scoring of your patient, let's say the score is higher, then there is a recommendation to monitor the patient more frequently. If let's say the patient is in general ward, you are monitoring only every 4 hours. So if the new scoring goes up, then it means you may have to monitor from every 4 hours, you need to monitor every 2 hours or every hour. And then we talk about urgency of clinical review. So if the score is already, let's say, a new score of 5 or a new score of 7, then possibly we may need to call the rapid response team, or we may need to call the medical emergency team to try to address the needs of the patient, to try to make sure that the patient does not deteriorate further. And then we also want to make sure that the competency requirements of the clinical team is adequate to undertake the review of the patient. So if you will look at this, for very high news scores, recommendations are given regarding the most appropriate clinical environment. So meaning, should we escalate? Should we bring the patient to ICU already? So what is the trigger for the calculation or for the early warning score? So a single score of 3 is already a red flag. So meaning, if you will look at this diagram here, if the SpO2 value of the patient falls below 91%, or let's say the SpO2 value of this patient is already 89, that's a single parameter, but the new score is already 3. So that is already a trigger for escalation. So meaning you are not able to treat this patient in the general ward anymore. So possibly you may need to transfer this patient to ICU directly and stand by for intubation, possibly. Or it's a composite score of 5 and 7. So meaning multiple parameters that will have a total score of either 5 or 7. So these are guidelines that you need to escalate the care of your patient already. So possibly call the rapid response team or call a more senior physician. So now we talk about the most important thing in the world right now, right? People are saying that there is a second wave, a third wave, even a fourth wave of COVID-19. So what is the role of news 2 scoring in COVID-19 patients? So let me just share some of the journals that are out there on COVID-19. So actually, since the start of the pandemic, if you are really curious about COVID-19, journals are free if it's about COVID-19. So there is always open access, because I think the clinicians across the globe are trying to help each other so that we can manage these patients better. So in March 2020, the World Health Organization actually recommended the utilization of early warning score to facilitate early recognition and escalation of treatment of deteriorating patients. So this was part of their guideline as early as March of last year. And then Italy actually had their own guidelines. So the diagram or the table that you will see here is actually a guideline that is created specifically for Italy. So what they did is they tried to correlate the early warning score with the clinical observation of the patient. So if you will look at this, early warning score is less than 3, but the patient is presenting with some respiratory symptoms. So how often should you monitor the patient? Then you need to monitor the patient every 8 hours. But let's say your early warning score is already greater than 4, and this is a critically ill patient. So how do we classify these patients as being critically ill? Possibly patients have a lot of comorbidities. Patients are elderly. That's why if you will look at the monitoring frequency for these types of patients, they are saying that these patients need continuous monitoring already. And don't forget that because of the waves of the COVID-19, the hospitals are actually being stretched to its full capacity. That's why we also need this type of monitoring. So how do you know which patient actually needs to be in the hospital and which patients can be managed at home? So if you will look at UK also, there are home care. So if you're a COVID-19 positive patient, they give you a kit. So there's an SpO2 monitor there, which the clinicians in the hospital are actually tracking. So you stay at home, you try to manage your symptoms at home so that the hospital is not overburdened also, so that the critically ill, the frail patients, the elderly patients, they have a space in the hospital. This was a study published. This was done in Norway, actually. This was only published in March of this year. Basically, they are trying to see whether the National Early Warning Score 2 on admission will help to predict disease severity and mortality rate of these patients once they are admitted in the hospital. So what they did was they tried to compare different scoring systems. So if you will look at the diagram here, they tried to compare a NEWS2 score greater than 5, NEWS2 score greater than 6, the QSOFA score, which is actually a scoring system used more for sepsis patients, and then the SIRS criteria, also again related to sepsis, and the CRB65, which is actually specifically related to patients with pneumonia. So if you will look at my box here, AUC means area under the curve. So ideally, to say that your scoring is the best, it needs to be as close to 1 as possible. So what do you see on the box here? NEWS2 score greater than 5 shows you an AUC of 0.786, while NEWS2 score of 6 and above is actually an AUC of 0.822. So your NEWS2 score greater than 6 gives you a better idea how your patients will fare in the hospital. And then when you compare it to the other criteria or the other scoring system available in the hospital, you can see that the others are clearly below your NEWS2 scoring. That's why in their conclusion, they mentioned that a NEWS2 score greater than or equal to 6 during hospital admission appears to be superior to the other scoring systems. And it's a good predictor of the severity of COVID-19 disease. And it's also a predictor whether your patients will survive or they will die in the hospital. The only limitation of this study, actually, this study had a lot of limitations, but the most glaring of all the limitations is they had a small sample size. This study only had 66 patients in their study group. That's why in their recommendations, you will see that they are encouraging people to do a similar study, but of course with more subjects or with more participants in the study. So this one is another study using the National Early Warning Score 2 to identify inpatient COVID-19 patients who are deteriorating. So what did they find in this study? Actually, what they found in this study is a single NEWS2 scoring is not enough. But what they are saying is you need to do a longitudinal trend of NEWS2 scoring. So if you will look at my diagram here, in the hours leading to the deterioration of the patient, around 33 hours into the hospital stay, they are actually seeing that the NEWS2 score of these patients gradually go up. So there is a sudden jump in the NEWS2 score of your patient. So they are saying that a single NEWS2 scoring may not be enough as a predictor of the morbidity of your patient, mortality of your patient, and the severity of COVID-19. However, if you do a longitudinal trend, so meaning you monitor NEWS2 score more often, then it will give you a better idea of the state of your patient. So if you will look at this in their summary, what was found, NEWS2 score greater than or equal to 5 had an excellent sensitivity to detecting deterioration in COVID-19 patients. So they are suggesting that we do more monitoring. So it's not only a one-off monitoring upon admission, probably in the emergency room. So they are suggesting that do it more often. You try to get the trend of your patient. So if you will look again at the guidelines of the Royal College of Physicians in London, they are saying that News 2 should be used when managing COVID-19 patients because it helps with the risk stratification of your COVID-19 patients. And then if you will look at News 2 scoring, if the patient, one question there or one parameter that is being monitored is the use of oxygen, so supplementary oxygen. But it's not a score between 0 to 3. So supplementary oxygen is just a yes or a no. Is your patient on supplementary oxygen or your patient is breathing room air? So what basically part of the recommendation of the Royal College of Physicians is if there is any change in the requirement for oxygen. Let's say initially the patient never needed supplementary oxygen, and then suddenly patient needs to be put on 40% FiO2 of nasal cannula. So they are saying that any change whatsoever in the oxygen calls for an escalation already with a competent caregiver. So possibly a more senior doctor, not the most junior doctor in the hospital. So you need to escalate already the minute there is a change in the oxygen requirement of the patient. And of course, they are saying need to increase monitoring to every hour. Let's say patient was only being monitored every 8 hours. But the minute you see a change in the oxygen requirement, you need to monitor every hour already if it has not been started yet. Now I want to show you another study. So this study also done using News2 scoring in COVID-19 patient, but this study was actually done, it's a multi-center study. So 8 hospitals in Europe plus a hospital in China. So the subject, actually the number of participants in this study is significantly greater to the first study that I have shared with you. So basically what this study is saying, so if you will look at the graph on the upper right, you see green. If you see green, it means the hospital is using only the National Early Warning Score to assess the patient, to assess the status of the patient, the improvement of the patient or deterioration. If you see blue, they are correlating the News2 score with the age of the patient. Of course, if the patients are older, then they have a worse chance, right, compared to a younger patient. And then the red is they are using the National Early Warning Score, and then they correlate it with blood tests that are taken upon admission of the patient to the hospital, plus the age of the patient. So in this study, what was the conclusion? So again, area under the curve. So the closer to 1, the area under the curve, the better it is. So what was their finding? The finding is News2 had poor to moderate discrimination for medium-term severe COVID-19 outcomes. So it means when you say medium-term, these are COVID-19 patients who are staying in the hospital for at least 2 weeks already. So they are saying if the patients are in hospital for 2 weeks and you are only monitoring using News2 scoring, then it may not be a very good prediction if the patients will survive or if the patients will not make it. So what they are suggesting, what they noticed is if you use the National Early Warning Score 2, and then you correlate it with the standard blood tests that they are actually ordering in the hospital. And these blood tests are as follows. The urea of the patient, CRP, GFR, the neutrophil count, the neutrophil lymphocyte ratio, plus the oxygen, supplemental oxygen flow rate if the patient is on it, and then the patient age. So they are saying if you correlate all of these things, it gives you a better predictor of your COVID-19 patients. So now we talk about manual computation or using a patient monitor. Because if you will look at the parameters, as long as you are monitoring your patients, you can see all of these parameters, you are actually able to compute manually whether for the score, for the News2 score of your patients. So this was a study done and published in JAMIA. Basically what they are saying, if you do manual calculation of your early warning score, The time required to record the parameters and to calculate the early warning score will take you about 4 minutes per patient. And because of the time taken just to get one reading of early warning score, the cost per observation is actually 1.67 pounds. So cost per bed per year, so this is on the average that you are monitoring early warning score 3 times a day or every 8 hours, probably every nurse shift, maybe at the beginning of each shift. They are saying the cost per bed will amount to at least 1,000 pounds per bed. So imagine if it's a 500 bed or a 1,000 bed hospital. So what is the benefit if you monitor early warning score using your patient monitor instead of doing it manually? Of course, if you are using your patient monitor to calculate for the News2 score of your patient, you get the result almost instantly. So there is reduced time to record and to calculate the early warning score because it automatically flows through. So whatever you are monitoring on your patient monitor, and then you will just click that I want to check the early warning score of your patient, it automatically flows through. So it gives you the score already. So that's one. Number two, because you don't spend a lot of time with the measurement just to get the scoring, there is also a reduced cost of calculation. And because you are using an electrical machine to do the computation, there is consistency in your calculation. And of course, when you have all of these, it leads to accuracy and completeness of recording because most of the time, all patient monitors will save the trends. So you will see the early warning score trend of your patient. You don't need to find the paper to write it down, especially now that most hospitals are going paperless already. So these parameters can actually be sent directly to your EMR system. This is just a sample of what it looks like on the patient monitor. So when you do your early warning score on the patient monitor, this is what you will see. So on the home page, you will see the early warning score here, and then you see that it's 11, so it's very high. So it means you need to escalate, probably send the patient to ICU, monitor continuously, and possibly have the rapid response team on standby. And then you will see the history. So what time was the last early warning score taken? And then so if you take it, let's say 3 times a day, you will see the 3 readings here. And then you just click on the time that you want to see, and everything will appear on the right. So during the 6 p.m. Early warning score reading, these are the parameters. So which one gave me the highest score? Why is my News2 score 11? So you can see here that, okay, the patient is on supplemental oxygen. And then the pulse rate of the patient is 146. So that is how they do it. That is what you will see on your patient monitor.
Sorry, Dr. Arlene, could you type it up because it's times go
Okay.
fast?
All right. Last slide. So in closing, we have learned what early warning score is and why it's important. We know that News and News2 was developed in the UK with the addition of hypercapnic respiratory failure and new onset confusion. So that made it News2 compared to News. And then there is a lot of clinical evidence to show that it actually helps. So there is a significant association with patient mortality when the News2 score is high. So if you will look at studies, there are a lot of studies also for COVID-19 patients. And then do we want to do it manually or through the patient monitor? Then it's up to us. So thank you very much. Mask up and stay safe.
Thank you so much. It's super interesting for your topics. Okay. Several questions here in the chat rooms. So from the audience, the first one is he asking that is the early warning score affected by geographical factors? In SE Asia, the climate is quite hot and humid. Does this affect to ICU patients' outcomes? Okay, it is in the chat room.
No. So okay. Let me see. Okay, so it's not affected. The geographical location of the patient is not affected. So wherever you are in the world, score will still give you the same thing. So should I monitor more frequently? So because if you will look at the parameters, it's not affected by ethnicity, it's not affected by the location of the patient. So if you have fever, you can still get a fever if you're in a cold place. You can get fever even if you're in a hot place. Your pulse rate will go up, your pulse rate can come down. So that one is not affected. When can we apply early warning score to COVID-19 patients? So normally what they do is once a patient is in the emergency room, they do a baseline early warning score already for the patient to try to see, can this patient be sent home? So just do isolation at home, monitoring at home, or should I admit this patient and send this patient to a high dependency unit, or send this patient directly to ICU and then escalate to the rapid response team? Is blood analysis not used for early warning score calculation? No, it's not. So again, the parameters, there are only 6 parameters. So the need for supplemental oxygen, the pulse rate of your patient, the SpO2 of your patient, the temperature of your patient. So those are things that are what we normally monitor our patients. So whether they're in the general ward or they are in the ICU. So these are the vital sign parameters that we monitor. So there is no blood test involved. Are there any more questions? Is there a standard of frequency of observation? So this one is dependent on the status of your patient. So normally, ideally, what we do is we do a baseline early warning score on these patients. So whether they are first admitted into the emergency room, we do a baseline. When they are first admitted into the general ward, we do a baseline. So because in the general ward, patients are not monitored frequently, right? They are not monitored continuously. So if you see that, let's say, normally we monitor them every 2 hours to 4 hours. So if you monitor, let's say when they are admitted, okay, I do my baseline. The score is okay, so I don't need to do anything. So when I do my next round of patient assessment, if you see that the early warning score values go up, then you need to monitor more frequently. So if you will look at patient monitors, there are also clinical guidelines there. So depending on the early warning score of your patient, the guidelines will advise you how often should you monitor. So let's say the score is 0, then you can monitor probably every 8 hours or as per normal in the general ward. If the score goes up to 5, then you need to monitor every hour. So that is how early warning score works. That's why it's also very beneficial for the junior nurses, especially if they do not really know when they should escalate to a more senior nurse, when they should refer to a clinician already. The early warning score will also help them. Actually, in the UK, what some people do, even when the patient is first admitted into the ICU, they do a baseline early warning score upon admission in the ICU. Because normally you see early warning score used in the general ward or in the emergency room, because the final escalation is actually in the ICU already, right? So if you see that the early warning score is very high, so you will need to transfer your patient to the ICU. But what some people do, what some clinicians are doing now, they even do a baseline early warning score upon admission to the ICU. Are there any more questions?
Yes.
Okay.
Yeah. Several questions.
Okay, so suggestion to use early warning score. Yes. So ideally, if we can have a standardized early warning scoring system like what the UK is doing, I think it will be best. And there are a lot of studies already on early warning score. I know in Asia, in ASEAN in general, early warning score is not standard for us. That's why I always like to talk about this so that we can educate everybody in ASEAN to try to change our practices. And then when you go to hospitals, different hospitals will have their own scoring system. So as I mentioned earlier, if you do not have a standard scoring, because sometimes you need to transfer your patient, right, from one hospital to another because this hospital may not be able to manage this patient. So if you are using a non-standard early warning score, then the minute you bring your patient to the next hospital for escalation of care, then your management may be different. That's why if we can push clinicians to use early warning score, I think that will benefit everybody. I think I have answered all the questions already, right?
Yes, thank you so much.
So that's all.
Yeah, so very
Thank you very
important
much.
for these situations in Thai, even in Thai. So
Yes.
thank you so much, Dr. Arlene again. Presenters, are you ready?
Thank you.
So yeah, for the